This is going to be a brief overview of ECGs or EKGs meant for the students in cardiopulmonary therapeutics. We're going to go through the basics and the steps of how you analyze the EKG to help you review the things that we covered in exercise physiology. So if you remember an electrocardiogram, this is a measurement of the electrical activity in the heart. It's looking at the pacemaker cells and the depolarization process. It's not necessarily telling us about the strength of the contraction or how much blood's being pumped. It's related to that, but it's about the conduction taking place in the heart. And there's different ways we can do this, and we'll talk about that. Remember, we have different electrodes that we wear, or the patient wears. We think about the limb leads, those are the arms and the legs. We have right arm, we have right leg, we have left arm and left leg. And we talk about the mnemonic that we use sometimes. We have the right arm, white on the right, and then we talk about snow on top of the grass, so the green grass and the snow. And then we say on the other side, smoke over fire. Easy way to kind of remember that. White on the right, smoke over fire, the snow sits on the grass. So if you have an electrode come off, you can quickly look at the color and figure that out. Then remember too, we have the different chest leads. We have V1, 2, 3, 4, 5, 6, and these give us kind of a transverse view of the heart. So if we think about the different limb leads, remember the limb leads, Roman numeral 1, 2, and 3. These are bipolar. It looks at the depolarization from the negative to the positive electrode for limb lead number 1. As we look at that, limb lead number 2, right arm down to the left leg, and then limb lead 3 is left arm down to the left leg. So we get 3 different views that way. And then remember, we have the augmented view. These are unipolar, remember that, so there's not necessarily a negative electrode. The 3 electrodes come together, and the heart itself is the negative electrode. So we're looking at the depolarization from the heart towards that electrode. And this is AVL, augmented lead left, AVR, augmented lead right, AVF, augmented lead foot, down to the left lower leg. Also remember too, we're not seeing here anything for right leg. None of that stuff's coming up. Remember, that is our ground. So that's our ground lead, and that helps keep the signal clear, etc. But it doesn't actually factor into these different views. So you put those those frontal plane leads together. Remember, we have limb lead number 1, which gives us a view this way. We have 2. We have 3, and then we also have the augmented 1, that AVR, AVL, and AVF. So what we end up with is 6 different frontal plane views. So 6 different views of the heart. And then also remember, we have the chest leads. Again, these are unipolar, so meaning the heart itself is the negative electrode, and it's looking at depolarization towards V1, V2, V3, V4, V5, and V6, so more of a transverse view of the heart. Okay, so 6 different views in a different plane. And that's the foundation of our 12-lead EKG. And we can see, looking at the 12-lead strip, we get 12 different views based on how we're looking at the depolarization. So let's give you an example of how this works out, how the leads give you a different view. So remember how the heart depolarizes. It depolarizes down in this direction. So this is where most of the depolarization is taking place, down in that direction from the atrium down to the ventricle. So we have limb lead number 2. So we remember that's right arm down to left leg. Okay, and this is our positive, and this is our negative. So the way to think about this is wherever the positive electrode is, remember the positive's down here and the negative is up here, there's a camera. This is my bad drawing of a camera. It's looking, the positive electrode is like a camera looking back at the heart and giving you insight into this part of the heart. Okay, and also remember, if you depolarize towards the positive, you get positive deflection on the EKG, so that's why you see this big QRS upward peak in this lead number 2, because the heart's depolarizing right towards that positive electrode, which acts as a camera again. Or if you look at it the other way, remember the heart is depolarizing again down this way. That's how the heart's depolarizing. We don't have a three-dimensional slideshow, but remember V2 is sitting about the fourth intercostal space, just to the left of the sternum. So it's looking at depolarization kind of out of the chest. Heart's depolarizing this way. The V2 is depolarizing kind of out towards you, on the screen. So that's why we have this big deflection in the negative position, because we have the heart depolarizing away from the positive electrode, causing a negative negative deflection on the EKG strip. Okay, key points to keep in mind. Remember, positive deflection, depolarize it towards the positive electrode. So when we see a QRS, that's the big positive deflection. It's because it's depolarizing towards that positive electrode. And vice versa, if we're looking at something here, we might see for V2, for example, we saw it before, depolarizing away from the positive electrode, we see it go down. We're going to look at the horizontal strips here in a second, but a small box is 0.4 seconds, a large box is 0.04 seconds, a large box is 0.2 seconds. So, 5 small equal 1 large box. Okay, and you kind of see that point right here, right? So you see 0.2 seconds, those boxes, and you see a small box is equal to 0.4 seconds, 0.04 seconds. Okay, analyzing a strip. So let's talk through the steps of how you analyze a strip. So by this point you should hopefully remember what your waveforms are. So the P is the atrial depolarization. You have the QRS, which represents the atrial repolarization and also the ventricular depolarization. And then you have the T wave, which is the repolarization of the ventricle. Okay, so we'll talk about all these numbers down here as we get going. And this is just a different way to look at it. So the P wave, atrial depolarization, ventricular depolarization, ventricular repolarization. Okay, step 1, how do we look at heart rate? Remember the rule of 300. This is a quick and dirty way to get the heart rate. So you look at, basically find a QRS that is on one of the big lines, okay, kind of the starts of the big boxes, and you can look at the whole strip and find it that way. And then you count the big boxes to the next QRS. And how you do that, you kind of a countdown. You take this and you say 300 here for one box, and you count down to 150, 100, 75, 60, 50, 42 is the next one. We don't encounter that too often that low, but you will sometimes. So, if we would have seen the QRS right here, it would have been a heart rate of 150, but because it's down here, it's 60. Okay, so a quick way to look at that. The assumption of a regular rhythm, though. You can't have an irregular rhythm and do it this way. You can also look at a 6-second strips and just count how many QRSs you see and multiply it by 10 as you see. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Simple multiplication, 120. And then, of course, in this world of technology and pulse oximeters and EKGs, we can just look at the monitor, but remember to keep in mind, if you don't remember this, that the monitor is really doing a QRS by QRS analysis of what the heart rate is. So you could have an irregular rhythm where you have a QRS like this and a QRS like this and a QRS like that, and here the heart rate might spike up on the monitor, then it might come back down, or you might have a sinus pause before you go back to a regular rhythm. And during this point here, it might actually change that way. So don't look at just one number. Look at it over 5 or 10 seconds. Get a sense of what the heart rate is. Don't just freak out if the heart rate goes up to 180 or drops to 40. Understand there's some variations. Let's take a few minutes and go through the steps of analyzing an EKG. And this is, as we talked about in lecture when we did this last spring, is when you're first learning this task, any task, it's good to have a step-by-step approach. As you become better at things, you'll recognize patterns. You don't really need to go through the step-by-steps. As you become more experienced, you can just look at it and say, ah, that's an irregular rhythm, or that's a ST segment depression, or that's AFib, or that's a bigeminal PVC. Okay, so as you get better at this, you don't need to go through all these steps, but as you're learning, as you encounter something that you're not unsure of, go back to the basics, go back to the step by step. Almost like we talked about with our clinical reasoning model, whereas you're first learning something, use the step-by-step approach. As you get more experience, you'll see a pattern, and you can skip around, jump around a little bit. But then when you're faced with a patient you don't know much about, or you're perplexed a little bit, go back to the step-by-steps. Same thing apply for EKG. So the first thing, is the rate normal? So remember, less than 60 is bradycardia, above 100 is tachycardia. Do the atrial and ventricle rhythms look different? Okay, so are you seeing basically a P wave with every QRS in a sense, and are they following each other? Does one follow the other? Or are you seeing kind of a atrium on one rhythm and a ventricle on the other? Okay, so first, what's the rate? And we'll talk later about implications. Sometimes less than 60 is okay, and definitely sometimes above 100 is what we'd expect, and other times that's an area of concern. Rhythm, we're looking for nice rhythm. You don't necessarily need to get a ruler out every time you do this. You can, eyeball it and say, okay, that looks like a pretty good rhythm. They look pretty equal as we go. Yep, that's a regular rhythm. And then let's jump back to heart rate. It's a regular rhythm, so we can use the rule of 300, right? We can go through and do that. We can find one here that's almost on the line, probably, right? We can say here, that one's almost on the line, so 300, 150, 100, and we're off a little bit here, so we might back that in and say, okay, it's probably about 120. Okay, so that's how we can do that. Look for a P wave. Does each QRS have a P wave? Make sure it's not inverted or upside down. Is it following that normal rhythm? So we talked about, again, there's a P wave, P wave, P wave, P wave, P wave down the line there. And then what's the interval, the PR interval? What's the time? So remember, you got the P wave. I'm going to do that in a different color. P wave, QRS. This from the beginning of the P wave to the start of the QRS should be, less than 0.2 seconds or one big box. We might have an extended. Remember, there could be an extended PR interval, or it could be an irregular rhythm. There's lots of things that could happen, but we're looking for that P wave, and then is there a normal interval? Look at the QRS. Is it tight? Is it uniform? Again, we want a nice tight QRS like we see here. We don't want to see a QRS that's like this, and we'll see that with our heart failure patients, with our patients who have had a heart attack. We might see that with them. We want it to be nice and tight because that shows that the ventricles are working together in a concise manner and in a uniform manner to pump the blood out. If we get this ugly and wide QRS, that's an indication that the ventricles probably aren't pumping as efficiently as they could. Are there any drop beats? So we look at this, no drop beats, but if all of a sudden, this wasn't here, we had just a run of a couple of these out, and we would see instead, a straight line there. That might be a drop beat. We lose a beat or two. Or are there any pauses? So pauses might be, a whole run of these that are just gone. It's just a straight line, and you're waiting. What's happening? Nothing happens. Okay, but then the heart starts back up again. And are there any pauses that take place? Is there a repeating pattern or QRS wave? So here you'd say yes, right? It's a normal pattern. But if you saw kind of a PVC in here, let's start all over. So we see our normal rhythm as we go. We see this, but then we have a real ugly and bizarre one, and we have another ugly and bizarre one, normal. Other ugly one and bizarre one. So is there a pattern, or is there just the occasional PVC that's taking place? Is really what we're thinking about, premature ventricular contractions. So let's try a couple. Okay, let's do the one on the bottom first. I like that one better. look at first the rate. Is there a normal rate? So we can say this is a 6-second strip. We can do a couple different ways. We can look at, this one looks like it's pretty close to the big block. So there's that, 300, 150, 100, 75, 60. So, you know, a little bit less than 60 because it's off that main line a little bit. Okay, so we know it's that way. Or the other thing we can do, we can just count how many QRSs are. 1, 2, 3, 4, 5, 6. So we can say, you know, it's approximately 60 beats per minute for our rate. Okay, is there regularity? Yes, I'd look at that and say yes, there definitely is regularity. Looking, is there a P wave with every QRS? Yep. Looking at the PR interval, let's pick one that's easy to find. So this one right here is on a big box, as we see right there. We would expect to see the start of the QRS here. So we do have an extended PR interval is extended. Okay. But then we look at the QRSs. These all look nice and uniform, as we expected, a short duration. Okay, so the big thing we take away from this, even if we don't know the name of it, is that we have an extended PR interval. And we'll, as you probably remember, this is a type 1 heart block. Okay, or first, I should say a first degree heart block, not a type 1, a first degree heart block where we have an extended PR interval. Now we look at this strip, and we can look at it and say, okay, do we have a normal rate? 1, 2, 3. You know, we have a kind of, if we look at this part of the strip, we have a pretty normal rate and rhythm. We could just look at this and, you know, use our big box rule and count from here to here if we wanted to, and get the rate that way. The rhythm's off, right? We look at that. There's something going on, as we see over here, where it, you know, these look like some PVCs. I'm jumping ahead on you a little bit, but you look at the PR intervals. These look like they're less in a big box. Do we see a repeating pattern of QRSs? Well, we see, first of all, these are nice tight QRSs, but these are ugly, bizarre, wide. So we see these are irregular. Okay, these are PVCs. Is there a repeating pattern? Well, we'd want to see a longer strip, right? We'd want to watch this and see, do these come back up again? So if you remember, the term for 2 PVCs in a row is a couplet. That's right, it's a couplet. So we see 2 in a row that way. Okay, so you see how I kind of went through the steps with that. In your handout from last year, you have all these different categories. I am not going to use this review talk to go through all these different categories, but good thing to go back and review these in your handout. And I'll also post the packet from last year on Blackboard with this. Just refresh your memory, we talked about this before. We use a 12 lead to identify different views of the heart, helps us pinpoint the location of an MI, and by us I mean the healthcare team. As physical therapists, we're really not determining where the MI took place, but it's important to understand what these different views mean and what they do. This is just a review of how the different leads give you a different view. Again, also think about the anatomical placement of the heart. Think also where those electrodes are at. So it makes sense, right, that V1 and V2 are right about here on the chest. So they give you more of the septal versus 3 and 4 are giving you more of that anterior wall. So you have to remember that your heart's kind of shifted a little bit. It's rotated in how it sits in the chest. At first response, you might think V1 and V2 are more anterior, and 3 and 4 might be more septal, but that's not quite the case because of how the heart's rotated. So go back to your anatomy book if you need to review that a little bit, and you see inferior views there and lateral views there. Okay, remember we also talked about a Holter monitor. This might be something that someone wears for an extended time period to look at their EKGs, their heart rhythm throughout the day. Typically you do EKG on someone, you're only getting a snapshot of their day, especially at rest. A lot of people don't have symptoms until they go home, they do things around the house, they go to work, they're around different people or different situations. This can capture what's going on in their life. So when should I be concerned? Well, we could go through all the different abnormal rhythms and look at that way, but we won't. Let's think about just broad categories. And this is a review from last time again, but the question you should be asking yourself is, does the rhythm majorly impact cardiac output. So if someone has the arrhythmia, does it change how blood's pumped to the heart? Does the rhythm cause a mismatch of supply of oxygen and demand of oxygen? And can the rhythm kind of degrade into more of a fatal arrhythmia too? Those are the things you're really asking yourself when you're concerned about EKGs or normal versus abnormal arrhythmias. So all these things here, you look at this and you say, okay, these are abnormal rhythms or dysrhythmias, but they're really not impacting cardiac output, and they're probably not going to degrade into a fatal arrhythmia. So yes, a premature atrial contraction or premature junctional contraction, it is an arrhythmia, but it doesn't really change cardiac output. Or you look at first-degree heart block. Well, this is someone who's an athlete sometimes, someone who's on certain medications. That can happen, but again, the QRS is nice and tight. Ventricles are pumping just fine. An occasional PVC, if I took everybody in the class and hooked them up to EKG, we'd find a certain percentage of people just have some PVCs throughout the day, and an occasional PVC is not that much of a concern. These are normal, but they can be potentially dangerous over time. So if sinus arrhythmia, but all of a sudden you have paroxysmal supraventricular tachycardia, that can degrade into a long-term tachycardia. PVCs that are new that comes on, those are concern. Sinus arrest, if we have a big sinus pause or a big sinus arrest. Sinus bradycardia with rates below 50, we're not talking about your triathletes here. We're probably talking about your patients who have heart disease or heart failure or inactive. So, some athletes will be this low, but these aren't the ones we're talking about. These are significant. They're definitely altering hemodynamics, and they can degrade very quickly into something else. So ventricular tachycardia, the ventricles pumping truly, faster than it should be and not pumping efficiently, or for example, the artificial malfunction of a pacemaker, a sinus rhythm or atrial fib with complete heart block, so the atrium and the ventricles aren't communicating at all. And then you see these are lethal, and these are emergency situations. So you could take the time and you could memorize all the different arrhythmias, and that's good to know many of them. But use the step-by-step approach. Think about how it affects hemodynamics, how it affects rhythm, how it affects cardiac output. And if you do those things, those will be the things that get you through this. Why we do this? Well, understand cardiac pathology, diagnostic process. But for PTs, this is probably the biggest one. It's going to determine safety during exercise. Can you push somebody? Should you push them back a little bit? Cut things back a little bit or push them more. EKG can help you. As I said in class, don't be intimidated by this information. You've gotten a lot of good experience in using EKGs and reading EKGs. Use that information, build upon it, contribute, and share information with nurses, doctors, other rehab professionals about EKGs. And this brings us to a close about your review of EKG. You can now go take the quiz, and we'll be building upon this information in class.